When we do cataract surgery, the primary goal is to remove a cloudy lens from a person's eye. A secondary goal is to allow that person to function quite well without being dependent on glasses. The good news is going through the cataract surgery, it's about a 98 to 99% success rate. And of those 1 to 2% chances of a complication, we can manage almost all of them. It's very rare that a person loses their vision from a complication due to cataract surgery. With standard cataract surgery, what we do is remove the cataract through a very small incision in the cornea. And after the cataract is removed, we'll put a lens implant inside of the eye that will allow the person to see clearly again. With standard cataract surgery, they're going to have to decide if they want that lens set for the distance or near, and then wear glasses to correct the residual, what we call refractive error. One of the reasons that people often need glasses after cataract surgery is because they have astigmatism. And astigmatism simply means that the cornea has more than one curvature for focus. It's kind of like the side of a football. A football has a flat curvature, and then it has another curvature perpendicular to that that's steeper. Well, our corneas are often just like that. And you can correct astigmatism with your glasses, or with contact lenses, or if you choose, you can use a lens implant at the time of cataract surgery. Unfortunately, insurances and Medicare don't cover the cost of a toric lens. So this is something that a patient has to decide if there's value to that. With a toric lens, we always use something called intraoperative wavefront aberrometry. And with this technology, we're able to achieve results that 95% of the time, they're able to see well enough to drive a car without glasses, to get up in the middle of the night and go to the kitchen and navigate without the need for glasses. One thing that's important for patients to realize is that even when we correct their astigmatism, we're still choosing either distance vision or near vision. So if a person decides to correct their astigmatism for the distance in both eyes, they'll see quite well in the distance, but they will need to wear glasses to see things up close. Their computer, reading material, taking a look at their watch or their cell phone. They will still need glasses to see up close. One way that a person can get around the need for reading glasses is something that we call monovision. Monovision is setting one eye for the distance, and that's usually the dominant eye, and then the other eye for reading. Now, this works for many people. I always have people try this in contact lenses first, though. Even if it's a trial for just a week, it gives them the opportunity to see if they'll be a good fit for this method of correcting both distance and near. If a person has used monovision at some point in their life with contacts and they thought it was great, they're a very good candidate to do monovision intraocular lens implant surgery. However, if they've never used it, they really need to go through this trial because a full 25% or so do not like monovision. And it's important to remember that we always do see better when we're using both eyes together, whether it's for driving or threading a needle. Our eyes work best, we get the highest quality of vision when we're using both eyes together. Another option in allowing a person to see at both distance and near is to use something called a multifocal lens. This works on a physical and optical property that's called diffraction. And it allows the lens to focus on objects in both the distance and near. Now these can be great lenses for people if they have no evidence of any other eye conditions. And if I find that they've got a good, healthy eye and they can have a multifocal lens, that's a very good option for people who want to reduce their dependency on glasses after cataract surgery. Another option for correcting both distance and near vision is something that's called the Crystal lens or the True Line, which is the same as Crystal lens, but it corrects their astigmatism as well. This is a great lens in that it doesn't have the effect of glare at nighttime. It gives a patient very good vision in the distance, and then it gives them some vision up close, but it's what we call intermediate vision. Intermediate vision would be something like your dashboard or your computer, things that you hold out at arm's length, perhaps your cell phone. However, a person can expect to have to use a very low power reading glass, perhaps a 150, to see fine print. I tell all of my patients when we use these lenses that you'll be able to see things quite well at the intermediate range, but you can expect to need some reading glasses to see, to read a paperback novel, something with small print. We expect that they'll need to use some glasses for that. One of the most exciting advances that we've had in cataract surgery is something called intraoperative wavefront aberrometry. This is a technology that allows us to gather data in the office, plug it into a cloud-based network, and then at the time of cataract surgery, we take an additional set of measurements that we were never able to do before. Those measurements, in combination with what we had in the office, are yielding results that we never saw possible before. Another very exciting development in cataract surgery has been what's called femtosecond laser surgery. This is a laser that fires 1,000 trillion times a second to give us very precise incisions in the cataract. Not only does it make what's called the capsulorhexis in a perfectly round circle, it also softens the cataracts to make it easier for the surgeon to get it out of the eye. Unfortunately, this is another new technology that is not covered by insurance, and patients will often ask me if I would have the femto done on my own eye. And the question is, yes, I would choose to have it done. In fact, most surgeons that I speak to that are cataract surgeons say that if femtosecond laser cataract surgery was covered by insurance, we'd be doing that on everybody. And I believe that's true. But I am glad that I've got thousands of cases of experience of cataract surgery. So I want to reassure all my patients that if it's not within budget, it's certainly something they should not fret about. They'll have a good outcome with even standard cataract surgery.